meeting. Tonight it's the Lung Foundation Australia and it's COPD training. I'd like to start off with the acknowledgement of country. So I wish to acknowledge and pay my respects to the traditional custodians of this land. I wish to pay my respects to the elders past, present and forthcoming. And I'd also like to extend my respect and acknowledge any Aboriginal or Torres Strait Islander people that may be present tonight. Just to let you know, I'm Tanya Budd. I'm one of the Regional Service Officers for Gippsland Primary Health Network, and I will be your host tonight. I'm just going to screen up here. Okay, so just a little bit of housekeeping. So ask questions via the chat section of Zoom, which is down the bottom. The evaluation survey will be sent out automatically via email at the conclusion of the webinar. The webinar recording will be available and a link will be sent out with the certificates of attendance. Turn on your video and audio to participate in the networking session. What do we do at Gippsland PHN? Our core functions are health planning, commissioning services, practice support, system integration, training and events, online registrations, the Link monthly newsletter and GPN membership subscriptions, and further information is available at our website, which is down the bottom. Digital health. Digital health provides us with a toolbox of technologies and techniques. Sorry, I've just lost that. That support innovative patient and caregivers model of care aimed at improved patient engagement, increasing accessibility, improving quality and safety, enhancing efficiency and sustainability. Ways that we can support you is with our data analysis and extraction tool, Polar, which a lot of the nurses will know. Polar is an exceptional tool. My Health Record, Health Pathways, and the Digital Health Guide. The Digital Health Guide is current. Gippsland PHN is currently offering all general practice doctors and professionals in Gippsland a complimentary subscription to the Digital Health Guide. To overview it, I think is probably the best way. It overviews all the apps and which ones are the better ones, if there's cost involved, if they're free, and I think most people live in the app world and on our mobile phones, so it is a really handy tool to have. Health Pathways. This is designed for use during consultation. It provides clear and concise guidance for assessments and referral, and it's created by local general GPs working in partnership with a range of professionals. Methodology to develop health pathways is a mechanism for collaboration and improvement. And you can see an example of health pathways from our website or using this email address. Okay, localising COPD pathways is differentiating between COPD and asthma. Pathways currently under development are the acute exploration of COPD, advanced and end-stage COPD, and COPD. If you're interested in being involved in the COPD clinical working group, contact Rochelle, who's on our digital team, and that's her email address. This link will be provided later. So tonight's agenda is we have a presentation. Sorry, I'm just going to close this. Presentation of COPD training update is Miss Jodie Hook. We'll have a question and answer time. We'll have an LRH Breathe Clinic program update by Jen, networking, and then our meeting will close roughly at around 8:30. Okay, this is a long presentation. Okay, population health statistics, 8,354 Gippsland people with an active COPD diagnosis and activity at their general practice in 2019-20. This just identifies, this comes from our polar system and it's de-identified data. It shows 3.7% of all patients. It identified 194 Aboriginal or Torres Strait Islanders, 69% were 65 or older, and 53% had a GP management plan or team care arrangement in place.
Sorry to interrupt, Tanya. We're still stuck on the digital health guide.
Oh, I thought you'd like that. Sorry, I've got two screens going. Is that better?
Population health statistics?
Yes.
Yeah, thank you.
Thanks, Jen. Okay, population health. COPD is the third most common cause of deaths for males in Gippsland after coronary heart disease and lung cancer. And it's the fourth most common deaths for females in Gippsland. A high risk of COPD for the following groups of people are people who smoke, people with social and economic disadvantage, Aboriginal and Torres Strait Islanders, and people exposed to air pollution. 73% of people aged 65 or older with COPD also have a cardiovascular disease. And this is just a graph that shows the COPD mortality rate per 100,000 people in the space of 2013 to 2017. This gives you a look at potentially preventable hospital admissions, and that gives you a guide over all the LGAs in the region. Okay, our presenters are Jodie Hook. She's a respiratory nurse expert. I think you guys can all read that. Okay. She's currently working at University of Melbourne, also holds an honorary research assistant appointment at the Institute for Breathing and Sleep at Austin Hospital. She's completed a postgraduate studies in community and health development and a qualified smoking cessation facilitator, and is trained in the Flinders self-management program and management of chronic breathlessness. We also have Jen Breeny. She's a registered nurse from the LRH Breathe Clinic Palliative Care Services. The clinic provides early access to palliative care, assessment and education for individuals at end-of-stage lung disease. Through connections with palliative care and GP services, it aims to enhance the quality of patient information exchange and planning with a view to improve quality of life for the patient and family in the palliative phase of their illness. She's done a Bachelor of Nursing at Monash, grad Business Management and Rural Health at Monash, and a Bachelor of Human Movement Science at CQU. And has quite a repertoire of working. Thank you, and I'm going to pass it over to Jodie.
Hello everyone, I'll just start sharing my screen to give us a sec. Can everybody see that okay? Yes? No?
All good.
Oh, good. So my name's Jodie, obviously, and my little bio, when I wrote it, I meant, oh, I sound a bit more exciting than I actually am. So I'm going to be talking about some COPD guidelines update. Feel free to ask questions as we go along, because, you know, that's kind of helpful for me to be able to see you. I can see a few little boxes, so it's nice to actually see other people in the Zoom. Now I'm just opening. Now, can you guys still see the screen?
Yes.
Yep. Okay, cool. Sorry, it was a bit glitchy for a sec. So the learning objectives today, you're probably all quite familiar with them. It's that improved detection of, can you see that? Sorry, it's dropped out. Looking at COPD.
Oh, sorry, when you say the screen, do you mean the content?
Yeah, can you see it?
No, I can't. I don't know if anybody else can.
Okay, let's just have a look.
We can just see you.
Oh, well, you know, I'm fabulous, so, you know.
No, we can't see it.
No, that's all right. Can you actually see this? And this worked so well before. Brilliant. There we go. Much better. So you're probably familiar with the learning objectives. It's looking at, you know, improved detection management and increasing the number of COPD action plans. I'm a bit of a stickler when it comes to COPD action plans. So if I go on about them, just put your hand up and move me along, really. So I'm going to start with Stepwise. Some of you may be familiar with the COPDX guidelines. They're the big guidelines that we use that are updated every 3 months with the latest evidence that we use for best practice management of COPD. As part of Stepwise, as part of COPDX, Stepwise has come out of that, and it's purely for people working in primary practice. It's a 2-page guide. It's a really relatively simple guide to use. It does get updated relatively regularly. So sometimes if you've got a hard copy, it might be worth having a quick sticky beak at the website to check that you've got the most updated version. Now, the thing with Stepwise is it's about managing patients when they're stable. Having said that, we also need to treat the patient's symptoms, not their spirometry. You'll probably see in Stepwise across that top band, they talk about FEV1, you know, with your mild to moderate to severe patients. A lot of patients have great spirometry, but really significant symptoms. So we treat the symptoms rather than spirometry. I think we've been in the habit going, oh yeah, FEV1's great, we're not actually going to do anything with you. And then we end up with patients that are quite symptomatic. So trying to manage those symptoms. They've purposely put the non-pharmacological interventions right up the top in the hope that we would utilise those as much as possible, and then looking at the pharmacological interventions. There have been some changes to Stepwise recently, and I'll do that in the next slide, but it's all about optimising function and optimising treatment and really looking at those comorbidities, because I don't think in all of my practice I've actually come across anyone that's just got COPD alone. If you do find anyone like that, feel free to refer them to me because they'd be much easier to manage. Yeah, so that's probably the reason. On the flip side of the Stepwise, you probably can't see it, but there's all the medications are on the back as well. The really good thing about that is it'll tell you what the medications are, whether they're a LAMA, a LABA, an ICS. I must admit, I sometimes struggle and I have to think, what is, oh, so they've given me this inhaler, which one is it? Is it ICS, LAMA, LABA? Is it a triple therapy, double therapy, whatever it is? So it's really about making sure that you've got the right medications. But like I said, we treat the symptoms rather than the spirometry. So the update from May is the most recent update that we've had for Stepwise. You may or may not know, I don't know. Previously, we had a thing saying that you could only receive triple therapy, so that's a LAMA, LABA and an ICS, if your FEV1 was less than 50% of predicted. They've changed that now because we like to make things difficult and hard. But now it's only people that have got, that are having multiple, excuse me, I'm just going to go and tell my cat off. I do apologise. I thought I'd booted her out. Triple therapy was to be limited to people that have repeated exacerbations and have quite severe symptoms. So we are now sort of expanding that patients out, the amount of patients that we can give an ICS to, but we really should be limiting it to those severe, severe patients. So in those moderate to severe disease. One of the things I do see a lot is that therapy is often stepped up by clinicians without checking patients' actual technique. I've been COPD CNC for many, many years, and I think out of the 4 years that I was running full-time clinics, I only saw 3 patients that have had correct technique on all 3 of inhalers. My favourite, I know Angela from the Lung Foundation has heard me tell this story before, but my favourite is actually watching a patient try and snort a turbohaler. That was the way that they were taking their medication, and of course we were escalating their medications quite significantly, but of course they couldn't use their inhalers. The statistics are 94% of patients don't use their inhalers correctly, which is a pretty significant number considering that's the only real management tool that we have. So really checking up their technique before we start stepping up therapy, because chances are they're probably not using it properly. I've actually seen people spraying their Ventolin on their lungs. I know that sounds silly, but you'd be amazed at some of the wonderful things that I've seen happen. So even swallowing the Seabury capsules, that's so it's making sure that we're reserving that that ICS for people that are quite significantly unwell. Now I'm going to be a little bit nerdy for a moment. I have a little bit of interest in the research related to COPD. I'm just going to talk to you briefly about 2 trials. This one is the FLAME trial. This was in 2014, I think it was. And it was a 52-week randomized control. And what it did was it was basically looking at Ultibro versus Seretide. And it provided really strong evidence that the LAMA-LABA combination, which was the Ultibro, was more effective than the Seretide in preventing exacerbations. And I think that probably goes a little bit about what we've previously known. We've always talked about people being on the Spiriva and Seretide, and I think all of us can think of times where we've seen everybody's been prescribed Spiriva and Seretide, but now we've evolved a little bit and we think we're getting far better control with a LAMA-LABA combination like an Ultibro. There's lots of them out there. It doesn't have to be this one. There's actually very little difference between the LAMA-LABA combinations. But it was published in the New England Journal of Medicine. Admittedly, it was sponsored by Novartis, who manufactures Ultibro. So, of course, they're going to find positive results. But it was a pretty strong evidence that we really need to be thinking about pulling people off the inhaled steroid and maybe moving them over to a LAMA-LABA combination. So it's worth having a look at those patients that are on steroids. Are they frequent exacerbators? Do they really need to be on that steroid? The next trial is the Wisdom trial, and that talked about, it was again a New England Journal of Medicine. So, these are significant journals that these are being published in, and it had 2,485 participants. And they found that once they took away a person's inhaled steroid, they actually didn't end up any worse off. So we left them on their other medications, took away their inhaled steroids, and they still did really well over a 12-month period. That is pretty significant evidence for us in respiratory land, saying that do we need to be giving these inhaled steroids? And probably not. So looking at what we need to do in terms of can we just put them on a LAMA-LABA combination? I find these studies quite interesting because everyone says to me, oh, only 2,485 participants. It's hardly anyone. That's, you know, we can't extrapolate that to a broader cohort. And I was one of those people. Having said that, I was working at the Austin recruiting for a study, and over 12 months, it took me 12 months to recruit 30 patients. So I now have a whole greater respect for those that run double-blind randomized controlled trials for 52 weeks. If they can get 2,485 participants, they're probably doing very well. So it's solid evidence in regards to, do we need to look at inhaled corticosteroids? And I promise I've only got one more slide about my inhaled steroid rant. So the things that we would really like people to consider is, when looking at inhaled steroids, does the patient actually have frequent exacerbations? Do they need to be on this inhaled corticosteroid? A lot of them don't. A lot of them are not having frequent exacerbations. When did they start on their inhaled corticosteroid? Chances are it was before we found all of this new research out in 2014 and 16 that that they probably would be better off with a LAMA-LABA combination. So do we need to review that? Like I said, are they actually regularly exacerbating? Are they exacerbating without us knowing it, perhaps? And maybe we need to ask about that. There is a really strong, there's quite strong evidence that an inhaled corticosteroid can increase a patient's risk of pneumonia. So we really do want to reduce that risk, and perhaps reducing their inhaled corticosteroid might help with that. It is a bit of a playing with their medications to check that you've got it right, but it's definitely something that's worth considering. I don't go taking everyone off their inhaled corticosteroids because Jodie said so, but it's more, let's review this medication. Would they be better off with a LAMA-LABA combination? The one caveat I suppose I have to this is that if they're one of those unique group of patients that are the asthma COPD overlap patient group, we always treat the asthma. Asthma is their primary, would be their primary diagnosis for treatment, so we treat asthma. So we would give them an inhaled corticosteroid. But I suppose in my service, everyone was an inhaled steroid. Doesn't matter where you were on the mild to moderate, how many exacerbations you had, everyone had a steroid. Everyone has a purple puffer. And so I'm the mean lady that suggests that we take away the purple puffer. So often I'm not a popular person because I want to take things away. But so yes, I'd probably think about those inhaled steroids. Now, in terms of the oral steroids, this is an interesting thing. We know that the systemic use of oral steroids is not recommended because it does increase mortality. There's really strong links there, and it does increase your risk of pneumonia and all of those other things that come with steroids, like your thinning skin, your brittle bones, you're getting more infections more easily. We often see patients on 5 milligrams of prednisolone to keep them ticking along. We really want to stop that. We're not doing them any favors by doing that. If they are having an exacerbation, you can give them a short and sharp course of oral corticosteroids, so prednisolone. We're talking for 3 to 5 days, 20 to 50 milligrams. That's it. You stop and you start. You don't need to taper anymore. I know that there was a big thing about tapering, a couple of, still around actually, really. But if it's less than 14 days, the evidence is really clear. You can actually just stop it. Having said that, patients love prednisolone, don't they? They do love their prednisolone because it does bring them quite a bit above their baseline. So you take them away and they drop to where they normally are. And then they're not experiencing that wonderful euphoria that they would normally get from prednisolone. So I do talk to patients a lot about prednisolone euphoria and how it will make them feel better than they really are. And they tend to do more when they're well. well, when they're feeling that good, and then you take away their steroid, and then of course they've done too much during that recovery phase, and then they fall in a heap. So it's really about pacing themselves while they are on that steroids, even though that they could feel that they could jump Mount Everest. It's about, you know, slowing them down a bit. It's ironic that somebody as fast talking as me says to patients to slow down, but it is something that we would recommend to them. So I'll stop ranting about corticosteroids now. This is my particular little ranty area. The next thing, I'm guessing all of you have probably seen a COPD action plan. These, I would hope that nearly every patient that you've seen has a COPD action plan. Chances are they don't. But this is your backup plan, I think, for want of a better idea, because most people will get sick at about 10 o'clock on a Saturday night once the GP and the pharmacy is closed, and they'll sit on that infection over Saturday, they'll sit on that infection on Sunday, they'll ring the GP practice on the Monday to say, hey, I'm not well. And of course, they didn't ring at 8 a.m. to get that last minute slot. So their next appointment is Wednesday. And by the time they roll into the GP practice, they're incredibly short of breath, their sats are in their boots, their chest is full of gunk, and, you know, the GP or the practice nurse is then umming and ahhing whether, do we need to get this person admitted to hospital? Is this an infection that we can manage at home? The idea with the action plan is you pre-plan for these eventualities. People with COPD are going to get an exacerbation. Doesn't matter how hard you try, doesn't matter how good your clinical practice is, they're going to get sick. It's just life. Unless you're in lockdown and there's no bugs, which means we've seen smaller presentations, but in regular times, they will get unwell. So the idea is, you clearly in the green part, you write down the medications they're taking now. So it's very clear that they're taking, you know, your Spiriva and your Seretide and your Ventolin. And you're writing the colours down, which is relatively helpful for them. And if you've got the information, writing down what their, if they're a CO2 retainer and what their FEV1 is. Now, this is useful if this plan comes to somewhere like the hospital, and they then take this plan in when they're admitted, and a nurse like me can look at it and go, oh, they're a CO2 retainer, let's not dial up the oxygen. Theoretically, that should happen anyway, but it's nice to have that extra layer of checks and balances, I suppose. So that's the green part, is if they have their normal, where they are normally. The orange bit is the 10 o'clock on the Saturday night moment. And the idea is that we give the patients power to start initiating their own treatment. What I find with a lot of COPD patients is they're quite disempowered after years and years and years and years. And the idea is that you know your body best. You know that you're becoming unwell, or your wife or husband knows that you're becoming unwell. They can see your changes. And that's when 10 o'clock on a Saturday night, you're unwell, you start your antibiotics, you start your prednisolone, or you start, just the antibiotics or just the prednisolone. You start one or the other as agreed with the nurse or the GP or whoever has decided this plan with you. It doesn't mean they don't come and see you though. What that means is when they ring the GP practice at 10 o'clock on Monday morning and they can only get that Wednesday appointment, by the time they roll around to Wednesday, they've already had 3 or 4 days of treatment and they're already starting to recover. So you guys can have a look at their stats and listen to their chest and go, oh, it's still sounding a bit rattly in there. Let's give you another course of antibiotics. Or, oh, it's excellent. You're doing really well. Keep coughing up that phlegm. Let's look at your action plan for next time. This really worked. Let's keep going. Or if the action plan didn't work, what do we need to do for next time? The red bit is the, do not class go, do not collect $200, you need to come to hospital. It gives some really clear signs if you're breathless, if you're worried. It also gives family members permission to call the ambulance, I think, a little bit, because, I know I have patients who are like, I'm not going to hospital, but this will give their partner or their children permission to say, look, you really need to go to hospital. So the action plan is what keeps them out of trouble, and it can work. You can use it in quite a collaborative manner. It's also really good for them to then take it to hospital or to clinic appointments with people like me, or to, if they're seeing a respiratory specialist. So that can sort of help in that regard. It should be reviewed every 12 months to check that it's working. Usually, you know, when you're doing your GP management plans, that's probably a good time to review it. They work hand in hand together, these plans. But the reality is you're doing pretty well if you've got a COPD action plan and you haven't used it in 12 months. I don't know if I've come across many patients in that particular situation, but really from mild, moderate to severe disease, somebody should have a COPD action plan and have it reviewed. So they should have also not only the plan written, but ideally they have a script for antibiotics which they have filled and ready. Have recognised that antibiotics expire. Most of these patients will have issues, you know, getting to the GP. You know, issues getting to the pharmacy. So the idea is if you've got the pharmacy already ready to go, they can easily just start it and then come and see you on the Monday. Is there any? I'm just looking. Is there any questions specifically about COPD action plans? No? No? Okay. I will keep on chatting. So the next bit is the exacerbation algorithm. So when people are unwell, often they'll call the practice or they'll call someone to say, hey, what do I need to do? The managing exacerbation algorithm works hand in hand with that action plan. So they've got the action plan and they're not quite sure what to do or should they start it. And they've called you. This provides whoever's on the other end of the phone some clear step-by-step guides on how to manage that particular exacerbation. So you can see that they're feeling unwell, they're coughing more, you know, you start more of their short-acting beta agonist. And you go, all right, they're still feeling worse. They've got a temperature. Right, we need to now start doxycycline. So it works. You can see that it works with the COPD action plan. And then you've got right down the bottom when you really need to send them to hospital. So, you know, these, you know, SpO2 was below 92% and whatnot. So it's a good one to have by the phone. I don't know what I've experienced is people become unwell, they want to call and speak to their GP, and of course the GP's in consults, and somebody hands, you know, the practice manager hands the practice nurse a slip saying, can you call back Joe Bloggs, he's not feeling well. And of course you've got to sort this out in the 10 minutes in between seeing clients and catching GPs and whatnot. So this is usually a pretty good algorithm to help you decide how to clinically manage that patient. And if they've got a COPD action plan, you can kind of avert disaster more often than not. So that's probably an easy decision-making guide for you. GPMPs, I'm preaching to the converted here. I don't need to sort of tell you how to suck eggs, I suppose, for want of a better term, but the GPMP is really the perfect time to look at inhaled medications. Are they on the right one? Does it match their symptoms and their lung function? And do they really need to be on that inhaled steroid? Again, I apologise, I've talked about inhaled steroids again. But it's really looking at those medications. One of the things that I find with a lot of the medications is people physically can't use them. You've probably noticed that the Respimat is quite difficult to turn. It's quite a stiff base. So if you've got a little old lady who's 89, who's arthritic, who's weighs all of 45 kilos, that is not the device for them because they physically don't have the strength to turn that device. So it's asking them, can you show me how you're using your device? There's, like I said, I've seen some really interesting ways that people have used their devices over the years. So it's about, can they actually use them? And if they can't, let's change it. Most of them are happy to change to one that might work a bit better for them. Ultimately, the long-acting beta agonists and the long-acting antimuscarins, they all do the same thing. They're made by different companies, but ultimately there's no difference between the two of them. So just pick a different device that you think that they're going to use, because something that they use is better than something that they never use at all. Looking at what exercise they're actually doing, not what exercise they would like to be doing, but what they're actually doing. And is there any, wriggle room in terms of, can we get them some exercise physiology or physio? I recently, a little while ago, I was in the Murray, and I was at a big GP practice, and they went, oh yeah, we've got a physio. Oh yeah, we've got an exercise physiologist. And I probably wasn't aware how easily this particular practice had access to these services. If you're lucky enough to have access to them, refer away, because chances are, I don't know how good your access to pulmonary rehab is. The evidence for pulmonary rehab in terms of improving lung function is really, really good. But if we can't get them to pulmonary rehab, anything, even 5 sessions with a physio or 5 sessions with an exercise physiologist to give them a home program, or just to encourage them a little bit, would be is the best option. A lot of them don't get up and move, and we know that if we strengthen, particularly their quads and whatnot, we improve their oxygen use, and that's probably where the evidence for pulmonary rehab comes from. So even if we get them walking, we're one step ahead of the game than we were before. Smoking cessation. I know it's something we all love and loathe equally. It's one of the most challenging parts of any sort of respiratory nursing is smoking cessation, and probably at times the least rewarding, because you don't get many wins on the board. But just asking every single time, are they ready to quit? Sometimes there's a glimmer of hope, and they are. I have a feeling there's a few more people that are willing to quit now in our current COVID climate. And interestingly, people are really struggling to figure out how to wear a mask out in Melbourne and smoke at the same time. I've seen some really fantastic ways of people putting it together. It has been really entertaining. So I'm hopeful that in Melbourne, in lockdown 2.0, we will maybe have a bit more smoking cessation, because people can't do it. They can't hold a cigarette, hold a coffee, a cigarette, and wear a mask at the same time. Like, it just can't be coordinated. So I'm a hopeful woman. So really asking them, and I will go through some resources for you for smoking cessation towards the end as well. So obviously with the GPMPs, making sure that they've got an action plan and they've got a script and antibiotic ready to rock and roll. Do they have a breathlessness plan? I know this is not necessarily a lung foundation thing that they have, and I do have an example, so bear with me for a bit. You probably can't see this super well, but I wrote this. This is Rupert's breathlessness plan. This is my example breathlessness plan. Rupert was my pug, so he was always breathless. So I used his name on my example, but it's about going, what are the things that work for you to manage your breathlessness, obviously the patient, to manage their breathlessness. So in this one that I wrote up, and I've used it for other people, it specifically says, stop speaking and moving. Give yourself time to recover. Use your fan, and I'll talk about fans in a sec, and choose your best breathing position. So that might be that hunched over tripod position. It might be over their wheelie walker or kitchen bench, or hands on knees, or even hands up above here. So it's asking them what works best for them. And I just cut and paste it. I know this is terrible, but I cut and paste a picture from an internet and dump it in this and give it to them to say, remember to use this posture. And then I get them to do the, what we call smelling the roses, and blowing out the candles. So it's a short breath in and long breath. So it's short breath in, long breath out. I know another colleague of mine calls it breathing around the rectangle. You breathe in on the short side and breathe out on the long side of the rectangle. I quite like that, but I can remember smell the roses, blow out the candles a bit better. And then going through the use your Ventolin, you know, your 1 puff, your 4 breaths with a spacer, your 1 puff, your 4 breaths with a spacer, and those sorts of things. And usually that will manage their breathlessness, and they've got a clear plan of what to do. Usually on the flip side, I'll also write some instructions for a family member. Usually they can be a little bit brusque sometimes, because I've said, you know, acknowledge symptoms and fear, help them access a fan, prompt and correct inhaler technique when they're not doing it slowly or using a spacer or whatnot, and give them time. Don't rush them. It takes them, you know, 5 to 10 minutes to recover their breath. And I do talk a lot about how breathlessness doesn't hurt you. It's awful, but it doesn't hurt you, and talking around those sorts of things. Obviously, having a influenza and pneumococcal vaccination. I think our vaccination rates are probably sky high this year. I used to work in the ACT, and I was very excited to see their flu numbers. They only had 4 flu cases so far this year. 4. I thought it was an error. I went back and looked at the data. 4 flu cases. I'm still recovering from 2017's flu time in Canberra. So I'm feeling hopeful for next year now that everyone's got their flu vaccinations. And a home medicines review. I've chucked this one in because an anecdote that I found, that when I did a home visit once for medications for a gentleman, and I was going through his medications, and he, like, by all intents and purposes, when I saw him in the clinic, when I spoke to him over the phone, he was doing really well. And I was going through his medicines, and I looked at it and I said, I didn't know you were on glucosamine. And he looked at me and he goes, oh, I'm not, jokes. They're for the extras. I'm like, what do you mean the extras? And I opened it up, and it was literally a bottle, big bottle, full of, he didn't want to take his Dig that day, so he kept it in that bottle. He didn't feel like taking his metoprolol, popped it in the bottle. So he would just pick which colour he didn't like, and he wasn't taking it. So if we hadn't done that home medicines review, we would never have known. Like, we just wouldn't have. So sometimes they're quite handy. I can honestly say that was the one time in my life that I've been speechless. I really struggled to speak when I saw that particular medicine bottle. So a home medicines review can be a really handy tool back in the clinic, trying to figure out what's going on with this particular patient. Oh, hang on. Breathlessness management. Be a fan of the fan. So we've been studying fans and in terms of reducing breathlessness since the 1980s. They come in and out of vogue. They weren't very trendy 10 years ago, and now they're trendy again. The thing with the fan is we don't really know how it works and why it works, I suppose, is the thing. We think that it's the air on the airway mucosa affecting the trigeminal nerve, reducing respiratory drive, but we're not sure. It's a really inexpensive tool that we can use in most settings. Every patient can have multiple fans in multiple rooms. So you can have one in the wheelie walker, in the bathroom, in the kitchen, in the car, in the handbag. You can have them as long as you remember to change the batteries. And my little fan, I've got a little lung foundation fan, and it really is, you're aiming it from about 15 centimeters from the face, and you're aiming it from that you can feel it on the top lip, and it's just here. And they're just fantastic. They really, really are. They make a big, big difference, and they're cheap and they're easy. The lung foundation cell, the one that I have, it has a little soft foam thing. So if you do bring it too close to your face, you're not going to hurt yourself. But you can get them from the $2 shop. Like, they don't have to be an expensive sort of investment in anything, but they are fantastic. Oh, ooh, I just made a joke. Hey, look at me. Oh, look at me. I'm on fire tonight. So there are really, now you can also, the Lung Foundation does have a little guide to patients on how to use a fan. So you can get that from their website as well. I've given a whole bunch of links to the PHN of where you can find all of these resources. So if you want, they can email that to you and you can just click the hyperlink. It's rather than having to hunt it about. Now my next favorite thing is nicotine replacement therapy. So nicotine replacement therapy, like we've got lots of options now. We've got the patches, we've got Champix, and we've got Zyban. Now, there is some good evidence to support the use of the patches prior to a patient giving up. We call it preloading. We like to give it a fancy term, I suppose. The most effective is combination NRT. So we're looking at a patch with a spray, a gum, an inhalator, or a lozenge. I tend not to use the 2 milligram lozenges. I just go straight for the 4 milligram. You will find there are lots of people out there who will not use the inhalator. Now, if you've seen the inhalator, the reason being, I have been informed, reliably informed by a number of my male patients, it's because it looks like a tampon. I know that sounds silly, but they will not use it. So, I get all of, I'm like, but this is great. This works really well. It's good for hand to mouth. And they're like, no, I'm not using it. So it's really something to consider. They just won't. Fair enough. The spray is your most fast acting, is your most fast, it's the fastest acting rescue nicotine replacement therapy. Having said that, it's also your most expensive, and lots of people can't afford it. The rescue nicotine replacement therapy is not on the PBS. You can't get it subsidized like the patches. So people do have to pay full price for it. And one inhalator is about $30. So there can be that price point difficulty. The cheapest is the gum. Most people use it incorrectly. You do need to chew it until it's peppery, and it's quite a strong taste. And then you stick it in the side of your mouth to let it absorb through the mucosa. Okay, so it just needs to sit there. And the same with the lozenge, it needs to sit under the tongue to let it absorb. But yes, I would say 4 milligram lozenge is the least offensive option for patients. I have learnt the hilarious hard way. You can imagine that clinic appointment when he explained to me what it was. Now, the Champix is, I do want to touch a little bit on Champix. We don't see that prescribed as much as I'd probably like. Champix basically is the most effective form of single pharmacotherapy for smoking cessation. Champix is the cat's pajamas in terms of what, look, its quit rate is still not high, but that's just for smoking generally. And nausea is your most common side effect from Champix. If people are drinking it with a full glass of water and with food, you can really reduce that nausea. Some people may need an antiemetic to try and help them along. And if that means that they're going to stick with the full course, it might be worth considering because the quit rate on Champix is really good. The good thing about Champix versus the patches is Champix and the patches with rescue NRT have a pretty similar quit rate. Champix is a little bit higher. The thing is, with the patches, you can get the patches on the PBS, but then you have to pay for all of the rescue nicotine replacement therapy, like your lozenges, your spray, and whatnot. Champix, you can get completely on the PBS for that course. So I think that's probably one of the selling points of Champix. But you do obviously end up with, if patients try and use it with patches or the spray or whatnot, they they can get quite unwell with nausea and headaches and fatigue and dizziness. So it's making it really clear to them, if you're on Champix, you're not on any other nicotine products. And it does have a slightly higher quit rate than Zyban. Now, Zyban, I don't see much of this, to be honest. I really don't see it prescribed often. I think because it was started out as a med that they would use in terms of mental health management, that it's probably not as popular, but it can be used with patches, and it can reduce the urge to smoke and withdrawal symptoms. They're a slow release medication, so you do need to take them for 7 days, then give up smoking, because you've got to reach that therapeutic level. If you take it in the morning, you don't get the same crazy dreams. All nicotine replacement therapy does can give people quite abnormal dreams. So I do warn them about that, to say that you will probably have some fruity dreams for a little while, but if they're warned, they're not quite as frightened when they get to it. Now, if after 7 weeks there's not a decrease in smoking, we stop it, because if you haven't seen anything after 7 weeks, you're not going to see anything. So it's important that you do. You may as well just stop it and see how the patient is going. And I think, yes, here we go. I knew I had a bit on the PBS. So the nicotine patches are on the PBS, and you can get a 12-week course once a year is what people are eligible for. Like I said, the combination NRT is not subsidised. So that is quite a bit of a frustration for us out in smoking cessation land, because, it'll be really good if we could give them the spray and those sorts of things. Champix is again on the PBS and can be prescribed. It's a streamlined authority to do that for up to 24 weeks for smoking cessation. So it can be a little bit fiddly. Some GPs are like, oh, I'll have to look it up and whatnot, but most people are pretty happy to prescribe Champix. And sorry, I've called it bupropion, but Zyban is also available on the PBS. Again, a streamlined authority for 9 weeks. Now, if you've got a patient on closing the gap, the PBS co-payment can reduce the cost for anyone that's involved in the closing the gap services. So that can sometimes be a little bit mean the difference between a quit attempt and a non-quit attempt. Now there's some great resources out there. My favourite at the moment is the New South Wales Quit Kit, and I'm just going to hold up what it looks like. Now, I must admit, I've sprung and I've splurged and printed it in colour, but it does work much better in colour, I will admit. And it's almost like a little workbook. Oh, there we go. And so they can read it and follow the steps and reflect and whatnot. Obviously, they need to be at that contemplation phase of giving up smoking. But the good thing about this kit is that you can get it in English, simplified Chinese, Arabic, and they do a version for Indigenous people. And I've had some really good feedback on the Indigenous version of the Quit Kit. You can just download it from their site. It's free. As nurses, we love everything that's free. So it works quite well, and you can work with the patient if they want to work with you. They can do it independently, but often I would do it in a smoking cessation clinic with them. We can talk about the outcomes from that Quit Kit. Now I've got a little thing in the corner there. I'm just going to move you all over to this side of my screen. You can see the little thing about My Quit Buddy. Now this is a free app developed by the Australian Department of Health. And I quite like it because you can set goals. It has the quit line pre-programmed in it, but it will tell you how many days and months and minutes actually, and hours, that you've been smoke-free. So it can be something that is really useful for patients to use. It will, if you specify in the app when your danger times are, It actually will send you a little message saying, keep going, you're doing really well. So a lot of people after dinner, for example, really feel a craving for a smoke. So it can send you a little message after dinner time to say, you know, keep going, you're doing really well. It can make a difference. I've had it on my phone for quite a while now, and I've saved something like $10,000 from not smoking for the amount of time I've had it on my phone. Not a smoker, obviously, but I had to test it out. I had a very bad habit. And it also, you can set goals, you can link in with other people who are on the app. It can tell you how much tar has left your body, or, you know, you've been smoke free for 10 days. Now this amount of whatever's has left your body. It's a really good free app for anyone with a smartphone. And I think the big thing is, particularly for the younger folks, it shows how much money they've saved. You know, that, I think that makes a big difference for them, being able to know, you know, oh, I've saved $200. I can go and spend that however. I knew someone who saved all of their money so they could buy a life-size R2-D2. That was his thing. He spent his $7,000 that he had saved on a life-size R2-D2. I'm like, well, if that's what got you stop smoking, go for it. You can have your R2-D2. So I highly recommend that. Like I said, it's free. Now, these resources here are all on the Lung Foundation website, but I just wanted to highlight them for you. There's, on the website, there is information sheets on each inhaler that is available, you know, that's gone to market. It's a step-by-step technique on how to take the inhaler. What I would do is, when I give a patient an inhaler, I would then print this this information sheet off, and then they would be able to read it step by step on how to do it correctly. It's a really good reminder, particularly if they've got multiple inhalers that do different things. Like Spiriva does one thing, Seretide does another thing, and now we're going to be moving them off to a Breezhaler, so they need to learn a new technique. I did read once that someone needs their inhaler technique reviewed every 3 months. I can't find that literature again, but I'm convinced I read that every 90 days they need their inhaler reviewed, because people forget. And I can say that I've been demonstrating these inhalers for years and still forget steps every now and then. Like, I don't hold my breath long enough, or I don't breathe out long enough, or there's something that I forget to do. So I find that these are quite useful. The middle resource is COPD, the Basics. It's a really short book. I'll just grab it here. Like, it's not very thick, it's only little, and it really talks about COPD in really simple terms for people to understand and get the basics. You don't have to read reams and reams of paper. If you want to read reams and reams of paper, it's this one, Living Better, which is the far one on the far right. It is quite a thick thing, but it gives the ins and outs of COPD, from oxygen to pulmonary rehab to pictures of your lungs to what each individual medication does. If you've got someone that's an eager beaver that really is craving information, this is a really useful resource for them, particularly if they're prone to Dr. Google. I find that this is a really good resource that they can use that will give them good, useful information, consistent information, for want of a better term. I think that is it. I've steamed through that, so I do apologise for chatting so much at you. I will have a quick look at the chat box. Is there any questions? Here we go. Oh, there's I don't know. I'm just having a quick look at the question for the health message on each mask. Thank you for supporting my quit goal. That's the statement for people that wearing the mask and trying to ciggy and coffee. So we can support goals that way. Yes, I'm sure that the people that make the nicotine replacement therapy should also consider changing the shape of the inhalator. But I have a feeling that so many of the cigarette companies are now buying into all of the nicotine replacement therapies. They don't really care. They're going to get your money either way, I think. I know that Philip Morris has just bought the Juul, the e-cigarettes. So I think that it'll be interesting to see what happens along those lines. But sorry, any other questions, concerns?
There is a couple of questions,
Oh, yep.
Jo, that came through with the initial registration.
Oh, yes.
Now, Mandy from Bass Coast Health asked, I'm new to the hospital at risk program, HARP, and find a lot of our clients have COPD. I'm very interested in management care plans and specialist clinic health providers that can help improve QOL and care outcomes for this cohort of clients.
Yep. In terms of sending them locally or moving them to a larger tertiary hospital? Did that give a context?
I'd probably say more so. Well, probably both, but I'd say given the current environment, it would be more localised.
Yeah, I think there is a bit of a challenge in terms of HARP. I think if you've got patients that are, if you've got an action plan, you've got a breathlessness plan in place, and you're having, it's a tough discussion, but people come in to me and the first thing is we'll talk about, what's wrong with them, what we're doing to fix them. And then I actually deviate a little bit from the Stepwise guide in that I will start having the advanced care planning discussion there. And that'll give me a bit of an idea about what they want and where we're heading, so I can know which services to refer them to. So if we're going all out, it's like, all right, well then we need to refer on and on, or are we just supporting you at home to figure out those sorts of things? But yeah, there's not a huge amount out there in terms of good quality evidence around what we should do for this particular patient cohort. We're hoping to do the right thing. Yeah.
Okay. What would you use as goals on a GPMP?
Anything that involves exercise, anything. Having a basically, yeah, exercise, using your inhalers. I would be really going back to the basics for a lot of these patients because they're not even managing the basics, making sure that they've got their pneumococcal vaccinations, they've got their flu vaccinations, they're even vaccinated for chickenpox and those sorts of things. They've got an action plan, they've got antibiotics, they've got prednisolone, they know what to do with those resources. And then, and are we exercising them? If we can improve that, particularly the strength of their thighs, we are going to improve their oxygen management. That the evidence is really good for that. And making sure that they've had their inhaler reviewed. One thing I didn't say earlier is often a lot of people assume that when a patient's been in hospital that they've had their inhaler technique reviewed. That doesn't happen. It doesn't happen. So if they've come back out to you as part of that plan, I would be saying we're reviewing their GP management plan is looking at their inhaler technique because they haven't had it looked at, and chances are the doctors have changed them.
And from Lee at the Ramanuck District Aboriginal Corporation in Sale, best management medically for COPD clients during the COVID pandemic. Is there new advice to be given in relation to asthma care planning other than if experienced difficulty breathing, shortness of breath, to call an ambulance and warn of possible COVID?
No, not really. Basically, what I'm seeing at the moment is actually we're not seeing as much COPD presentations to hospital because obviously I'm in Melbourne at the moment, so we're in lockdown 2.0. We're actually not seeing anyone in our HARP services because they're all isolating and they're not getting sick. So we're like, oh, we don't have any new management plans for these patients in COVID because they're not unwell. But basically, there's no. We would treat a COPD patient with COVID the same way we would treat anybody with COVID, and we just need to let the ambulance know that they do have the potential for COVID-19. But yeah, there's nothing specifically. I think that there will be something more to come out of this post-pandemic. A lot of work was done in the Asian region post-SARS. So I have a feeling, and we escaped SARS and MERS and whatnot, but I think there'll be a different kettle of fish once we've sort of made it through this. I know a lot of research is in the pipeline in regards to COVID. So watch this space. I think I think everybody's just trying to muddle through at the moment. I know I am. So I think that's probably the case for COVID at the moment.
Okay, and there's also a question from Denise. In your experience, do pharmacists check inhaler technique during home medication reviews?
No, is my short answer. But it depends on your pharmacist. So I have often, as part of my inhaler technique education, I will come across pharmacists and they will ask me for education on the inhalers. They will know LAMAs and LAVAs and inhaled corticosteroids, and they will be able to pick up in that home medicine review that the patient is on 2 long-acting beta agonists or 4 inhaled corticosteroids. So they'll be able to sort the wheat from the chaff, but not all of them consistently will look at inhaler technique. If you've got a good relationship with that GP, with that pharmacist, you may know that they will go and check that. Check the inhalers, but it's not routinely done, unfortunately. And even in the hospitals, the thing that the ward staff used to say to me, we don't need to check inhalers because we've got you. I'm like, but I'm one woman covering the whole hospital. Like, I can't do inhalers for everyone. So I think there's an added, we really need to encourage the attitude is inhalers are everyone's problem. But yes, I have yet to win that war, and not all pharmacists are good with that. But it doesn't hurt us asking, because they really should be. They tell us how to take tablets, with food, with water, don't take grapefruit juice with it. So it should be the same for inhalers. But obviously not everyone lives in my happy land where everybody does that.